Here's what you're about to find out. Why researchers found Amish communities surprisingly healthier than expected. The one plant, modern medicine warns, could actually harm you. How plant knowledge outlasted every generation that carried it. What drug companies are secretly hunting inside traditional herb gardens. There are roughly 370,000 Amish people living in North America right now. Most of them have never had a primary care physician. Not because they cannot afford one, not because doctors are unavailable nearby. They simply do not go. And the average Amish adult lives just as long as their English neighbors, sometimes longer. That is the fact that stops researchers cold. How does a community with no standard medical care maintain that kind of health outcome? The answer starts in the garden. Walk up to any traditional Amish homestead in Lancaster County or Holmes County, Ohio, and you will notice something behind almost every house: a kitchen garden. But not the casual sort, a working garden that functions more like an outdoor pharmacy. Rows of specific plants, carefully tended across generations, each one with a precise purpose. These are not decorative. Every plant earns its place. Grandmothers know what each one treats. Daughters learn it young. The knowledge moves person to person, not through books. Researchers from Ohio State University, who spent time embedded with Amish communities in the early 2000s, came away genuinely puzzled. The communities showed lower rates of certain chronic conditions, asthma, allergies, cardiovascular disease, than surrounding non-Amish populations in the same counties. Some of that gap comes down to diet and physical labor, but the plant knowledge kept coming up in interviews. The families were not just avoiding doctors. They were actively managing health at home with a specific botanical toolkit that has stayed largely unchanged for over 200 years. So, what exactly are these 12 plants? And do they actually work? Those two questions sit at the center of a genuine debate in ethnobotany, the scientific study of how human cultures use plants. Because the Amish are not unique in having botanical traditions. What makes them unusual is this: their tradition is intact. Most cultures lost their plant medicine knowledge as cities grew and pharmacies arrived. The Amish never fully made that transition. Their tradition did not get interrupted. That makes their garden an almost unprecedented living record. Before we get to the plants themselves, it helps to understand why the Amish resist conventional medicine at all. It is not a blanket rejection. Amish communities will accept emergency care. They go to hospitals for broken bones, appendicitis, difficult births. What they resist is the ongoing medicalized management of everyday health. In Amish theology, the body is a gift from God, and daily care is a personal responsibility. Handing that responsibility to a professional institution, and especially to pharmaceutical companies, feels like a spiritual abdication. The garden is part of honoring that responsibility. The plant traditions themselves trace back to German-speaking Switzerland and the Alsace region of France, where the first Anabaptist communities formed in the early 1500s. When those communities emigrated to Pennsylvania in the 1700s, they brought seeds, not metaphorical seeds, actual seeds, pressed into cloth packets, carried across the Atlantic. Many of the plants in Amish gardens today are European in origin. They were cultivated there for centuries before anyone crossed an ocean with them. The knowledge is old. The question is whether it is also right. Plant number 1 is echinacea. Every Amish garden has it. Purple coneflower, tall and bristly, blooming from midsummer through early fall. The roots are harvested in autumn, dried and steeped into a tea that Amish families drink at the first sign of a cold or respiratory illness. The belief is that it shortens illness and strengthens the immune. What is striking is that this belief aligns almost exactly with what modern clinical trials have found. A 2015 meta-analysis in the journal Evidence-Based Complementary and Alternative Medicine reviewed 24 randomized trials and found echinacea reduced the risk of catching a cold by about 35%. Plant number 2 is chamomile. Small white flowers, feathery leaves, and a smell that most people recognize from tea bags in grocery stores. For the Amish, chamomile is what you give a colicky infant, a child with a fever, or an adult with stomach cramps. It is brewed into a light tea and administered several times a day. German chamomile, Matricaria chamomilla, contains compounds called apigenin and bisabolol. Both have demonstrated anti-inflammatory and antispasmodic effects in controlled studies. The gut-calming properties are real enough that pharmaceutical companies now isolate the active compounds for use in commercial formulations. Plant number 3 is yarrow. It grows wild across much of North America, but Amish families cultivate it deliberately. The leaves are feathery and soft. The flowers come in flat-topped clusters, white or pale yellow. Yarrow is the wound plant. Fresh leaves are pressed directly onto cuts and scrapes. An Amish farm is a working operation. There are axes, scythes, machinery, and animals. Minor cuts are a daily reality. Rather than using bandages and antiseptic cream, many Amish families reach for yarrow first. The plant contains achilleic acid and flavonoids that encourage blood clotting and reduce localized inflammation. Its Latin name is Achillea millefolium, named for Achilles, who ancient Greek soldiers supposedly used it for battlefield wounds. Plant number 4 is valerian. This one does not look like much. A tall, gangly plant with small, pale pink flowers that smell slightly unpleasant when fresh. The root is what matters. Dried valerian root is used by Amish families almost exactly the way modern people use sleeping pills. Chronic insomnia is treated with a valerian tea taken before bed. Anxiety and nervous tension get the same remedy. Valerian root contains compounds called valerianic acid and isovaleric acid, which appear to interact with the GABA receptors in the brain, the same receptors targeted by benzodiazepine medications. The mechanism is not fully understood, but the effect on sleep quality in human trials has been consistently positive. Plant number 5 is calendula, orange and gold petals, cheerful looking, and sometimes confused with marigolds. For Amish families, calendula is the skin plant. The petals are infused in olive oil or lard, then cooled into a salve that goes on rashes, eczema flare-ups, cracked nipples during nursing, and slow-healing skin lesions. Calendula officinalis contains triterpenoids and flavonoids, compounds that suppress local inflammatory responses and inhibit certain bacterial strains in laboratory settings. A 2009 randomized controlled trial published in the Journal of Clinical Oncology found calendula cream outperformed standard petroleum-based ointment for radiation-induced skin burns in breast cancer patients. The Amish did not need that study to tell them it worked. Plant number 6 is plantain, not the banana, the broadleaf weed that grows in every lawn and gravel path across North America, Plantago major. Most people spray it with herbicide. Amish families pick it. A fresh plantain leaf, chewed briefly to release its juice, pressed against a bee, sting, or insect bite, draws out the venom and stops the itch within minutes. Children learn this by age 5. The active compounds are aucubin and allantoin, both of which appear in commercial wound care products under pharmaceutical names. The Amish get them straight from the nearest patch of ground. Now things get more interesting, because the first 6 plants on this list are defensible by anybody's standard. Clinical literature supports them. Their mechanisms are understood. A mainstream physician would likely shrug and say, yes, those work, more or less. But the next 6 plants push into territory that is genuinely contested. And that is where the Amish tradition becomes a more complex and more revealing story, because the question is no longer just whether these plants work. It is why these particular families have trusted them for so long, and what that longevity of trust tells us about both their knowledge and its limits. Plant number 7 is elderberry. Black elderberry, Sambucus nigra, has been in Amish medicine chests since the Pennsylvania settlements of the 1700s. The berries are cooked into a thick syrup with raw honey and sometimes ginger. This syrup is given during cold and flu season, daily as a preventive, and in larger doses when someone is already sick. Elderberry became a subject of intense research interest in the 1990s, when an Israeli virologist named Madeleine Mumkuoglu studied it during a flu outbreak in a kibbutz. Her results showed that patients taking elderberry extract recovered in roughly 4 days compared to 8 days for the placebo group. It launched a global supplement industry. Plant number 8 is garlic. Amish families do not use garlic merely as a food ingredient. They use it as medicine aggressively, in ways that would surprise most modern cooks. Raw garlic cloves are crushed and eaten at the onset of an infection. Garlic-infused honey is given for coughs. Garlic oil is dripped into ears for ear infections. This sounds eccentric until you look at the compound responsible. Allicin, produced when garlic is crushed, is a potent, broad-spectrum antimicrobial. Laboratory studies have shown it effective against Staphylococcus aureus, Escherichia coli, and even drug-resistant strains. The Amish are essentially using a crude natural antibiotic, and they have been doing it since before modern antibiotics were invented. Plant number 9 is St. John's wort. This one is genuinely controversial, and it is worth being precise about. Amish families have used St. John's wort, a bright yellow-flowered plant, for what they call melancholy and nervous exhaustion. Modern clinical research has tested it specifically for mild to moderate depression. A Cochrane review in 2008, covering 29 clinical trials and over 5,000 patients, found St. John's wort was more effective than placebo and similarly effective to standard antidepressants for mild to moderate depression, with significantly fewer reported side effects. But, and this matters, St. John's wort interacts with a long list of pharmaceutical drugs, including anticoagulants, birth control pills, and antiretrovirals. It is not harmless. Context is everything. Plant number 10 is comfrey. Here the story gets complicated. Comfrey, Symphytum officinale, has been used across European herbal traditions for centuries as a bone healer and joint treatment. The German folk name for it translates roughly as knit bone. Amish families apply comfrey root poultice to sprained joints and minor fractures. The active compound, allantoin, does promote cell proliferation. Studies confirm it reduces pain and swelling in sprains, but comfrey also contains pyrrolizidine alkaloids, compounds that are toxic to the liver when taken internally over long periods. External use appears safe. Internal use does not. The Amish tradition here is partly right and partly a genuine health risk, depending on how the plant is used. Plant number 11 is peppermint. Amish families grow spearmint and peppermint in abundance, often in contained beds, because mint spreads aggressively and takes over a garden if given the chance. Peppermint tea is the first response to headaches, indigestion, nausea, and tension. But the Amish also use peppermint oil topically rubbed into the temples for headaches, or diluted and applied to the chest for respiratory congestion. Clinical trials support peppermint oil for tension headaches with impressive results. A 1996 study in cephalalgia found peppermint oil applied to the forehead was as effective as acetaminophen in reducing headache intensity. The menthol in peppermint activates cold receptors in the skin, which interfere with pain signal transmission. Plant number 12 is mullein. This is the least well-known plant on the list among modern audiences, but possibly the most impressive. Mullein, Verbascum thapsus, is a tall, stiff plant with thick, fuzzy leaves and a long spike of yellow flowers. Amish families harvest the leaves and dry them for respiratory use. A tea made from mullein leaves is given for chronic coughs, bronchitis, and asthma. The leaves can also be dried and smoked, which sounds paradoxical as a respiratory treatment. But the mucilaginous compounds in mullein leaves coat and soothe inflamed airway tissue. Laboratory studies have found mullein leaf extracts active against several respiratory pathogens, including influenza virus strains and Mycobacterium tuberculosis. So 12 plants, 12 specific tools for specific problems, and most of them have at least some clinical basis behind them, which raises the question of how that happened. How did a community with no formal scientific training arrive at this particular list? The honest answer is, by selection over a very long time. Every generation of Amish families tried things. What worked got passed on. What did not work quietly disappeared. This is not intuition or mysticism. It is a slow, multi-generational filtering process, something like an extended clinical trial, run without controls or documentation, across 2 centuries and a dozen American states. But there is a problem with that elegant story, and the problem is serious enough that researchers who study Amish health cannot ignore it: survivorship bias. The traditions that survived are the ones that felt like they worked, but feeling like something worked and actually working are not the same thing. Colds resolve on their own in 7 to 10 days, regardless of treatment. Minor wounds heal regardless of what leaves you press against them. If an Amish family gives echinacea tea at the first sign of a cold and the cold passes in 5 days, they remember that echinacea worked. If it passes in 10 days, they remember. Human memory is not a reliable instrument for measuring botanical efficacy. There is also the matter of what the plants do not treat. Amish communities have higher rates of certain genetic disorders than the surrounding population, a consequence of the founder effect, where a small founding population limits genetic diversity. The most studied is Ellis Van Creveld syndrome, a form of dwarfism. There is no plant in any garden that addresses a chromosomal condition. Amish communities also show higher rates of some cancers that go undetected longer than in the general population, because there is no routine screening. The plants handle what the plants can handle. The rest does not simply go away. And here is the harder turn. Some Amish communities, in recent decades, have begun to recognize that specific conditions require medical intervention, and the resistance to seeking it has cost lives that did not need to be lost. A meningitis outbreak in an unvaccinated Amish community in Ohio in 2014 hospitalized 12 children. Polio appeared in an unvaccinated Amish community in 2022. In New York, in a country that had been functionally polio-free since 1979. These are not failures of botanical medicine. They are failures of a system that works reasonably well for the conditions it was designed for, encountering conditions it was never designed to handle. The academic community has responded to Amish medicine with genuine interest and some caution. Dr. Daniel Winslow at the University of Virginia has argued that traditional botanical knowledge systems represent what he calls compressed empirical data, meaning they contain real information about plant efficacy, buried inside cultural practice, waiting to be extracted by systematic testing. His view is that ethnobotany is an underused shortcut to drug discovery. You begin where generations of users already finished, but other researchers, including Dr. Paul Uffitt at Children's Hospital of Philadelphia, argue that uncontrolled traditional use tells you almost nothing reliable, and that treating it as data leads to false confidence in treatments that may be neutral at best. The debate sits inside a bigger question about modern medicine itself. Pharmaceutical companies do, in fact, start with plants. About 25% of all pharmaceutical drugs are derived from plant compounds. Aspirin came from willow bark. Morphine came from poppies. Quinine came from the cinchona tree bark, and it saved millions of lives in malaria-affected regions. Digitalis, the cardiac drug still used today, came from foxglove, a plant that European herbalists had used for heart conditions for centuries before anyone isolated the active compound. The Amish are not practicing something alien to mainstream medicine. They are practicing an earlier version of it, one that stopped at the step before laboratory isolation. That framing matters because it changes what we are actually asking. The question is not whether plant medicine is legitimate or fringe. It clearly has legitimate scientific roots. The question is about precision and dose, about knowing exactly how much of what compound is in the tea you just brewed, versus knowing that a standardized tablet contains exactly 500 milligrams of a purified active compound. The Amish are working with imprecise tools. Sometimes that imprecision does not matter. Sometimes it does. A poultice of calendula on a rash is a low-stakes intervention. Treating a serious bacterial infection with garlic alone, while rejecting antibiotics, is a high-stakes one. There is another dimension to this story that almost never gets mentioned in popular accounts. The Amish relationship with plants is not just medical, it is economic. A bottle of echinacea extract from a pharmacy costs $12 to $20. A packet of echinacea seeds costs $2 and produces decades of harvest. For large families, Amish households average 6 to 8 children. The cumulative cost of pharmaceutical health management for common illnesses would be substantial. The garden is not simply tradition. It is also a rational economic calculation made by people who handle their own finances carefully and do not health insurance in the conventional sense. The Amish mutual aid system also plays a role that outsiders rarely understand. When serious illness strikes, a cancer diagnosis, a major surgery, a hospitalization, the community pays, collectively. Congregation members contribute to a shared fund. This is not insurance in the legal sense, but it functions similarly, without premiums or bureaucracy. Knowing that catastrophic care is covered by the community changes the calculus around everyday health management. You do not need to visit a doctor for a cold or a sprained ankle when you know the community has your back for the things that actually require a hospital. Consider an October morning in Lancaster County, a kitchen where the wood stove has been burning since 5, the windows fogged with condensation. Bundles of dried herbs hanging from the ceiling, mullein yarrow, chamomile, an elderly woman at the table, grinding dried echinacea root in a ceramic mortar, her granddaughter watching from across the table. No book open, no recipe written down. Just a living transmission of specific knowledge about specific plants, conducted in the ordinary flow of a kitchen morning. Outside, the fields are in their late harvest. The air carries wood smoke and the dry smell of turned earth. This scene, or something very close to it, has played out every autumn in these communities for over 200 years. And that continuity is precisely what makes ethnobotanists pay attention. When knowledge survives in unbroken transmission for that long, it has been tested, not formally, but repeatedly, by real people with real stakes. Dead plants, failed treatments, and wasted time do not get passed down. Only the things that justified their place in the garden came through. That does not mean everything in the garden is correct. It means that everything in the garden was worth keeping by the standards of the people keeping it. Separating those two things, what felt worth keeping from what was actually effective, is the work that modern researchers are still doing. There's a parallel story happening right now in pharmaceutical research. Drug companies face what researchers call a discovery drought, an increasing difficulty in finding genuinely new compounds for antibiotic development in particular. Some research teams have turned back to ethnobotanical records as a starting point. The logic is direct. If a traditional culture used a plant consistently for bacterial infection across generations, the compound responsible for any real effect is at least a candidate worth isolating and testing. Amish botanical practice is one of several traditional medicine systems being reviewed in this way. The garden, in other words, may not just be a relic, it may be a research cue. The modern wellness industry has noticed, too, but not always in ways that serve the underlying knowledge well. Elderberry syrup is now a multi-hundred-million-dollar industry. Echinacea supplements line every pharmacy shelf. Calendula cream appears in high-end skincare lines at $40 a jar. In most of these commercial forms, the connection to the original Amish or European herbalist tradition is purely cosmetic, a nostalgic label, a rustic font, a word like traditional on the packaging. The active compound concentrations vary wildly. Regulatory oversight in the supplement industry in the United States is minimal. The Amish grandmother with her ceramic mortar is working with a more consistent product than most commercially sold alternatives. What is actually being transferred when an Amish mother teaches her daughter which plant to use for what? It is not just botanical identification. It is a whole framework for reading the body, reading the season, and making a judgment call about severity. A child with a mild cough gets mullein tea. A child with a cough that has lasted 3 weeks and is producing discolored mucus gets taken to a doctor. The tradition includes that distinction. The line between self-treatable and serious is part of what gets passed down. The knowledge is not simply about plants. It is about thresholds, knowing when the tools you have are sufficient and when they are not. That framework, that threshold knowledge, is exactly what most modern people have lost. Not because they are careless, but because the threshold got handed to professionals. You feel unwell, you call a physician. The judgment about severity is outsourced. There is obvious benefit to that. Physicians are more accurate than grandmothers at diagnosing pneumonia. But there is also a cost. A population that has lost its threshold knowledge becomes one that floods urgent care clinics with viral respiratory infections that would resolve on their own, while sometimes missing warning signs of serious illness that they no longer know how to read. The Amish tradition is not a model that most people can or should replicate in full. Rejecting vaccines for childhood communicable diseases carries real risks that the plant garden cannot offset. Avoiding routine cancer screening means catching tumors later, when outcomes are worse. These are not small caveats, they are serious ones. But embedded inside a tradition with those real limitations is also something genuine. A body of botanical knowledge refined over centuries that modern science is only now catching up to systematically test. The tradition is not right about everything, but it is not wrong about nothing. And that nuance is uncomfortable for both sides of the usual debate. People who celebrate traditional medicine do not want to acknowledge the real failures. People who dismiss it entirely do not want to acknowledge that aspirin, morphine, quinine, and digitalis came from the same source. What the Amish garden actually represents is messier than either story. A partially correct, partially limited, economically rational, culturally coherent system for managing everyday health, built by people who had no other option and refined. The 12 plants are still growing behind Amish houses across Pennsylvania, Ohio, Indiana, and 31 other American states where Amish communities have established themselves. The knowledge is still being transferred in kitchens, not classrooms. No journal article preserves it. No regulatory body approves it. It persists entirely because enough people found it useful enough to keep passing it forward. That is either the most compelling argument for its value or the most compelling illustration of its limitation. Possibly both. Modern medicine began in a garden. Virtually every pharmacology textbook acknowledges this. The compounds that save lives today were, at some point, a plant that someone noticed, used, and passed on. What the Amish have done, across 2 centuries in American soil, is kept that original step alive and intact in a form that researchers can still study. Whether or not you would trade your own physician for a kitchen garden, the information stored in that garden has value. Some of it has already been extracted by pharmaceutical science. Some of it almost certainly has not. 2 centuries from now, researchers may look back at the Amish botanical tradition the way we look at Peruvian indigenous knowledge of cinchona bark, as an underestimated source of information that was there long before science caught up with it. Or they may find that most of it was placebo and comfort, effective in human terms, but chemically inert. We genuinely do not know yet. The research is ongoing. The gardens are still growing. And in a kitchen somewhere in Lancaster County this morning, a grandmother is teaching someone something that no textbook contains. Whether that knowledge should stay in the kitchen or move into the laboratory is a question that plant scientists are actively arguing about right now. Where do you stand on it? Tell me in the comments.